Today we'll be discussing obesity as a disease in its own right. Then we move into how we assess people living with obesity and how we arrive at a diagnosis of clinical obesity. I will end this presentation with a case discussion that lets us apply these principles to a real patient scenario. The fundamentals is, as Dr. Irata mentioned just now, obesity is a complex chronic disease with heterogeneous presentation, not simply a matter of willpower or lifestyle choices. The excess and abnormal adiposity drives a wide range of complications and raises the risk of premature illness and death. Strong evidence shows that overweight and obesity increase the risk of chronic conditions and reduce quality of life. Because of all this, obesity deserves the same approach as any other chronic disease: early recognition, individualized intervention, and long-term support. We are all very familiar with this key finding from the NHMS 2023. However, mind you, this data is based on BMI more than 25 for overweight and more than 30 for obesity. If we are using the Asian BMI categories as recommended by our CPG, the numbers will be higher. Nevertheless, let's walk through the breakdown on the next few slides. Here we see the prevalence broken down by sex and by age group. As we can see, the prevalence of obesity is higher among the women, and men have higher prevalence of overweight. Looking across age groups, both overweight and obesity rise steadily into the middle decades of life, with obesity peaking in the 50s. This tells us that screening should be routine across all adult age bands. These charts break down the data by ethnicity and locality. We see meaningful differences across ethnic groups, with the highest obesity prevalence among Indian ethnicity, highest prevalence of overweight among the Chinese, and Malays somewhat in the middle. Whereas overweight and obesity affect both urban and rural settings strikingly similar. So the takeaway is that obesity is a widespread issue affecting every community we serve, regardless where they live. Here, the data is segmented by education level and by household income. As you can see, those with tertiary education have higher prevalence of overweight, those with secondary education have higher prevalence of obesity, and those with primary education have higher prevalence of overweight. This challenges the assumption that obesity is concentrated in any single socioeconomic segment, and it reinforces that our screening and intervention efforts need to reach every patient, not just specific group. This is also another family infographic and real case scenario we are seeing in our clinic. Our fellow Malaysians are living with multimorbidities, and we have studies from Finland and UK that shows once patient is living with obesity, the onset of second and the third disease will be much more earlier compared to those with normal weight. And this graph from World Obesity Atlas illustrates the broader impact of overweight and obesity at a populational level. Beyond the individual weight, obesity carries a substantial burden in direct healthcare costs as well as societal values, reducing productivity due to presenteeism, absenteeism, premature death, and rippling spillover in terms of other health expenditure. Visualizing these trends help us understand why early proactive management of obesity is very important. And because of all that, congratulations to Profila and our CPG contributors. This is a remarkable shift in paradigm to treat obesity as a disease. After all, obesity fulfills the criteria of a disease as illustrated earlier and later on. And true enough, even modest weight loss translates into meaningful improvement across a range of conditions. For example, a 5 to 15% reduction can lower HbA1c and may even achieve diabetes remission while improving blood pressure, lipids, PMOS symptoms. These principles here is to tailor the weight management target to patient-specific complications. This lets us set a realistic, motivating goals rather than just chasing arbitrary number on the weight measurement. And the key to obesity screening is in primary care is an annual BMI measurement for every adult patient. Making this routine ensures we don't miss patients who may not raise weight as a concern themselves. Think of BMI as the entry point that flags who needs more detailed assessment. While BMI is a useful starting point, it has important limitations that we need to understand. BMI doesn't distinguish between fat and muscle, nor does it tell us where the fat is distributed. For example, these two doctors have the same BMI of 22.3, but they have a very different body composition. The Caucasian have body fat of 9%, and the Asian doctor have body fat of 21%. So, BMI should never be used in isolation. It must be interpreted alongside other measures. Waist circumference captures central adiposity, which is a stronger predictor of cardiometabolic risk. We know from Asian studies populations that have elevated diabetes and severe risk lower cutoff, 90 cm in men and 80 cm in women. But for patients whose BMI is more than 35, it is unnecessary to measure waist circumference as it loses its predictive values. Our CPG was ahead of its time to recommend assessment of comorbidities in the management of obesity. Early last year, the 2025 Lancet Diabetes and Endocrine Commission proposed a new framework for defining and diagnosing clinical obesity. The Commission's work shifts us away from relying on BMI alone towards a more clinically meaningful definition based on illness and organ dysfunction. Let's unpack what that means over the next several slides. Here, we begin to lay out the Lancet Commission diagnostic approach. The central idea is to distinguish between obesity as a risk state and obesity as an actual disease. This distinction has real implications for how we prioritize and manage our patient. As you can see here, BMI is useful, but again, it doesn't tell us where is the fat, how much is the fat, and whether the excess adiposity pose health problems. Here we see the practical application of the clinical obesity diagnosis as proposed by the Lancet Commission. First, we need to determine where is the excess body fat. So we can either use at least one body measurement of body size and BMI. The body measurement can be waist circumference, it can be waist to hip ratio, or it can be waist to height ratio. And we combine it with BMI. Another measurement possible is to use two body measurement, or we use a direct body fat measurement, such as using a DEXA scan or body impedance analyzer. Once we establish that there is excessive body fat, then we confirm whether the excessive body fat have any symptoms, any signs of organ dysfunction, and does the individual have limitation of day-to-day activities. The presence of signs and symptoms of organ dysfunction and limitation of day-to-day activities will mean that this patient could be living with clinical obesity. As mentioned before, waist circumference is a practical method of measurement of excess body fat. Other approaches are available, but most are not readily available or convenient in clinical setting. Increasingly, in the era of GLP-1 receptor agonist treatment and metabolic and bariatric surgery, the use of body impedance analyzer, such as BIA, is gaining more momentum and will be very useful in the management of obesity, even in primary care. This table summarizes again the difference between clinical obesity and preclinical obesity. So for clinical obesity, we are looking for signs and symptoms, limitation of daily activities, and complications that manifest as a result of altered organ functions or end organ damage. And this diagram illustrates how excess adiposity can affect multiple organ systems throughout the body. A complete assessment means systematically considering each of these potential areas of impact from the CNS, respiratory symptom, metabolism, liver, renal, reproductive, upper airways, cardiovascular symptoms, of course, urinary symptoms, musculoskeletal, lymphatic symptoms, as how these symptoms and signs affect the daily functioning of the patient. This whole body view helps us identify complications that might be otherwise missed. And it is a very important reminder that obesity assessment is genuinely multi-system work, and we who are working in primary care are very suitable to do all this. To move forward in obesity management, we must first go back to history taking, the importance of clinical history. This is an important practical framework for taking weight history organized around the OPQ-RST mnemonic. We explore the onset of obesity, when did the weight gain started, how was the weight when the patient was 17 years old, in the college, early 20s, in the 30s, in the 40s, and what was the patient heaviest weight. And then we move on to precipitating factors. What are the life events that could lead to weight gain? For example, college years, long commuting hours, marriage, divorce, or even financial loss. And again, as we all know, the pregnancy is an important again period that can cause any weight gain. So we go through all this to understand patient lived experience. And then we go through the quality of life. How was the patient? How is the weight affecting the patient? And what have the patient tried to manage to control their weight in the past? What was successful? What patient think attribute to weight loss? And what patient think have caused in weight regain? And also to consider the setting, what was the patient's doing, their environment when the patient gained weight. And we also want to establish whether there has been any cyclical or gradual pattern of weight loss, weight regain, plateau, and weight regain. This will allow us to be more empathetic to the patient's struggle in our management of obesity. This slide emphasizes that our assessment need to be holistic and systematic. These are the common ones that should not be missed when we are assessing patients who are living with obesity: hypertension, of course, metabolic syndrome, OSA, MAFLD, diabetes, dyslipidemia, osteoarthritis, and even cancer. And these 4M's approach include monetary aspect that can guide us to build a complete picture that links the patient adiposity to their functional status and complications, as well as, again, empathy to their lived experience, whether they have insurance, whether they are on any stable income, and this will also determine whether patient can afford certain type of treatment and what access to health food they can afford. Another important part of the assessment for patients living with obesity is screening for conditions that affect eating behavior and physical activity. This includes screening for major depression disorder using the PHQ-9, screening for generalized anxiety disorder using the GAD-7, binge eating disorder, late night eating disorder, substance abuse disorder, attention deficit hyperactive disorder, which increasingly more detected among the adult population, especially lately, and also any history of psychiatric illness or trauma. Intimate partner violence or domestic violence used to be a taboo, but women who are living with obesity may face overlapping vulnerabilities, including weight stigma, emotional abuse, social isolation, and financial dependency. In obesity care, clinicians should be alert to domestic abuse and coercive control, particularly when weight-related shaming, fear, or loss of autonomy affecting the patient's ability to engage in treatment. And the WHO recommendation is not for universal screening, but looking for clinical clues, for example, unexplained or repeated injuries, mental health symptoms, any chronic somatic symptoms, any issues with sexual reproductive health, period of antenatal or postnatal, or any behavioral cues that could point out to IPV, intimate partner violence or domestic violence. And the recommended and validated questionnaire formulation is this WAST, Women Abuse Screening Tool, that I believe we can do for patients who fulfill these clues. Also, sleep is another key domain in obesity assessment. Disorders such as OSA, obstructive sleep apnea, are common in people living with obesity and can worsen metabolic health. they will feel more hunger, their appetite will increase, and even though they are not eating a lot, their metabolism is very low, so they are not losing any weight. So screening for poor sleep and sleep apnea should be part of our routine evaluation. The stop bank criteria questionnaire should be used for screening for patients with clinical suspicion of OSA, and the Epworth Sleepiness Scale ESS may be used to assess daytime sleepiness. The stop bank criteria consists of snoring, asking whether patient is snoring a lot at night, whether it disturbs the sleep of others, tiredness, observed apnea, patient feel choking, or wake up at night, feel choking, a very dry mouth, and high blood pressure. Bank is for BMI, age, neck circumference, and gender. And the diagnosis of OSA should be confirmed using sleep study or polysomnography that can be either level 1, level 2, or level 3. Level 1 and level 2 is normally done in the hospital, whereas level 3 can be done at home. And this will require referral to the ENT or our respiratory physician for a proper sleep study and proper interpretation, as well as proper treatment for patients who are living with obesity and OSA. And ideally, the patient with suspected OSA, the sleep study should be performed within 6 months of initial consultation. As we all know, the danger of micro sleep and so on. So this is another area that often neglected that we in primary care can give another important consideration. And also recently, the World Health Assembly has recognized steatotic liver disease or fatty liver disease as part of important component in our NCD approach. And this has shown by the multi-society guidelines by the European Association for Study of Liver, Diabetes and Obesity, CPG, that recommend FIT4 scoring for patients with diabetes or obesity plus more than one cardiometabolic risk, or patient with transaminitis, that we should do the FIT4 scoring that consists of the ALT, AST, and the platelet. And based on that scoring for patient with whose FIT4 score more than 2.67 should be referred to the hepatologist. Patient with intermediate scoring 1.3 to 2.67 should be done a fibroscan or elastic liver smoothness measurement to check for any evidence of liver fibrosis. And catching this early allows timely referral and intervention. And it's a good example of why obesity assessment must look beyond the weight itself. And this diagram describes the development of chronic kidney disease in patients with obesity. In the past, we used to understand that the main risk factor, the main causal for end-stage disease are diabetes and secondly hypertension. But now we also understand that excessive and abnormal adiposity also leads to inflammation, fibrosis, hyperfiltration at the glomerular level, and subsequently altered kidney function and albuminuria and CKD. So doing urine albumin creatinine ratio is very important for patients who are living with obesity during our clinic consultation. Now moving on to another key area when we are assessing patients who are living with obesity is cancer. We know from a body of literature that patients living with obesity often have limited access to screening for cancer. It is more difficult, for example, to do pap smear for patients with BMI more than 40, for example. The diagnosis is also more delayed. It's difficult to get a sample from patients who are living with obesity for biopsy, for example. And the treatment, the chemotherapy, the calculation of chemotherapy dose, radiotherapy, the targeting of the radiotherapy, and even surgery will require ICU backup. So that means patients who are living with obesity have more difficulty for screening, for diagnosis and treatment of cancer. And we now have data from US that shows an earlier onset of cancer among patients who are living with obesity. And this earlier onset of cancer bring a worse prognosis apparently. So in Malaysia, these are all the recommended cancer screening that is part of the National Strategic Plan for Cancer Control Program. For breast cancer, the age is more than 30 years old. It's recommended to do a mammogram And for colorectal cancer, for age patient 50 and above, for cervical cancer, patient who are sexually active, age 30 to 65 years old. For oral cancer, patient opportunity screening for walk-in patients to dental clinic and community outsource community outreach program. And we are also moving for lung cancer screening. And also another important cancer that is often neglected is the liver cancer, hepatocellular carcinoma, which is currently the fifth leading cause of cancer in Malaysia. And the recommendation is for every patient who have cirrhosis need to be offered surveillance using ultrasound of the liver combined with the alpha-fetoprotein. So this is a whole package of cancer screening that we need to offer to our patients who are living with obesity, who fulfill the age criteria so that we can detect cancer much more earlier. And this table is from our CPG, another valuable reference, listing all the common medications that can contribute to weight gain. So this is part of our assessment, part of our counseling and workup for patients living with obesity. This goes by the antidepressants, the mirtazapine, the SSRI, the monoamine oxidase inhibitors, the medication for epilepsy, gabapentin is commonly used for pain management, for neuropathic pain, pregabalin, the antihistamine, the antipsychotic, Seroquel, clozapine, olanzapine, risperidone, alpha blockers and beta blockers, steroids, of course, and our medication for diabetes, especially the insulins and the sulfonylureas, as well as hormonal agents. So reviewing a patient's medication is easy but often overlooked step in our assessment, where appropriate switching to weight neutral alternative can support the patient's goal and our shared decision making in the management of obesity. And also equally important is to screen for illicit drug use. This newspaper cutting is from The Star early this month, highlighting the widespread illegal use of retatrutide, which is a triple agonist that has recently been shown to bring weight loss up to 30% after 104 weeks. The data was published at the American Diabetes Association scientific meeting in New Orleans, I think 2 or 3 weeks ago. But we must be aware that this medication has not been approved even by the FDA for obesity management. But this medication has been readily available in TikTok, in social media, and some of our patients could be using this medication. And so far, we have anecdotal evidence and experience. Patients are developing side effect, anemia, sarcopenia, and so on because of using unregulated, unapproved medications for the weight management. So after all the assessment of the history taking, the medications, the symptoms, and the investigation, we follow this structured management approach from the Lancet Commission for Clinical Obesity, whereby for patients who are living with obesity, the management must be evidence-based, it must be personalized, shared decision-making, and success must be defined beyond the number or the weighing scale by improvement of the signs and symptoms of the organ dysfunction or organ damage. And for patients who are living with preclinical obesity, this patient will require health counseling, will require monitoring over time, and even active weight loss intervention for patients at higher risk of developing clinical obesity and other obesity-related diseases. So please offer follow-up, offer appointment to see this patient again, or you can refer this patient to weight loss community programs, such as we have the COSPAN, we have the Wellness Hub, and others in the community. And for the patient with clinical obesity, we give them appointment for further treatment, especially after considering the stage of the obesity. So after diagnosing the clinical obesity, like other disease, we stage the disease. Now I would like to introduce the Edmonton Obesity Staging System from the Canadian CPG, and this staging system has recently been adopted by the Obesity Society, American Diabetes Association. And this staging moves beyond the BMI to grade the actual impact of obesity on patients' physical, mental, and functional health. These frameworks help capture that multi-dimensional living experience. Staging is what turns a measurement into a meaningful actionable diagnosis, as well as prioritize treatment because we have limited resource, we have definitive time, we don't have infinitive amount of resources to treat everyone. So by staging obesity using this EOSS, going through the medical domain, whether there is established disease, severe disease, or organ disease, mental domain, whether there's a subclinical risk factor or severe disease, and functional, the NEOA, the OSA, whether the patient is having established or severe disease. This will again help us to prioritize which patient we should offer which treatment. And this slide summarizes obesity assessment in clinical practice. As mentioned before, our main tool is the BMI. We use BMI as a screening tool. And then we use waist circumference to determine where is the body excess, where is the excessive adiposity, is it central adiposity or peripheral adiposity. In our setting, we can use a waist circumference, we can use body impedance analyzer, for example, or waist to hip ratio, for example, to determine that this patient is actually having excessive adiposity. And then, as mentioned before, we assess for obesity-related conditions. Patient can be very muscular, athletic, but have zero related conditions. Or patient can be just slightly overweight or just on the lower end of the obesity, but already have diabetes. So this patient already in the clinical obesity that require further assessment, and we do the staging. So by staging, we can determine whether this patient will require what kind of treatment, how intensive is the follow-up and monitoring, and so on. So to summarize again, the guiding principle of obesity management, our aims is to keep patient metabolically healthy, and to prevent or treat coexisting comorbidities. Equally important, we must actively fight stigmatization that people with obesity often face and work to restore their well-being, positive body image, and self-esteem. We have evidence that patients who are living with obesity, even in Malaysia, a study done by Prof. Rohana, they face recurrent stigmatization even though they have always been tried to lose weight. So managing obesity well means caring for the whole person, not just the number on the scale. We want to restore the individual's well-being, positive body image, and self-esteem. So our CPG, coming back to our CPG recommendations number 1, which gives us the mandate to treat obesity as a disease, to screen for obesity, to measure, to provide assessment, and to staging into one workflow that we can use in our clinic. And we use this as our mental roadmap whenever a patient living with obesity present to us. And with the complete framework, we are ready to apply it for our real case. So we are going to a case discussion. So ladies and gentlemen, I would like to present to you a patient of mine, 39 years old. She's a housewife who came to my clinic for a routine follow-up for diabetes. She has a strong family history of cardiovascular and metabolic disease. Her father, she lost her father due to diabetic food complications. Her mother to ischemic heart disease, and her brother due to stroke. She had type 2 diabetes, hypertension, and dyslipidemia since 2019. And she's on subacute Novomics, 32 TDS, metformin, dapagliflozin, pentopril, amlodipine, and atorvastatin. So this could be another patient that we see in our clinic. So how do we approach history taking for patient living with obesity? Maybe we can have any response from the chat box.
Yeah, I think participants can write what do they think with regards to history taking in the chat box.
Yes, thank you. I've seen several responses in the chat box.
Right?
Yes, of course.
Okay, good.
Thank you very much for the response. So we are talking about the OPQRST. But before that, another important thing is first to ask for permission. Ask permission to discuss because you are going into a personal territory. Patient might first come to your clinic to continue medication for diabetes, for hypertension, or even for your RTI. So it is also part of a good practice, even included in the Canadian CPG to use the 5 A's. So the first A is for asking permission to discuss weight. So we discuss the onset of the obesity. Like for example, for my patient, she started to her weight at 17 years old was 80 kilogram, and her highest weight was actually the current weight, which is 120, and her lowest adult weight was 100 kilogram. And I tried to track. So normally we try to track the weight, try to draw a graph ideally, but patient might not be able to recall everything. So this is what we get. And she claimed that she gained more weight during the pregnancy and starting from there on. And because of the increasing in body weight, she have several symptoms such as bilateral shoulder pain. She have gastritis, and also she had tried previously using stevia on and off, and she was seen by dietitian 2 or 3 times before. She attempted a brisk walk once in a month, and she's still able to climb a staircase so far. And in terms of physical activity, at the moment she's still able to do most of the house chores. And his husband is a security guard working 12 hours shift, and she have one son who is 13 years old. And in terms of the temporal pattern, she lately having this weight going up and down since having the menopause. So this picture shows us how a careful and empathic history uncovers beyond simply asking what they eat or how much they move, and patient will be thinking that we are trying to understand and really trying to help them rather than just trying to blame and find fault with regard to their weight gain. So our second question is, how would you approach the physical examination for a patient living with obesity? Think about a focused and system-based examination that include any signs that are relevant to obesity-related complications. So how would you consider the physical examination for patient living with obesity? Can we share in the chat box? Yes, we do a BMI screening, waist circumference, full vital signs. Yes, any sign of insulin resistance. Yes, if you have access to a body impedance analyzer, you can do that in your clinic. Yes, neck circumference is important, especially if you are suspecting OSAs. Thank you very much. Thank you very much for your response. So the physical examination for obesity is again systemic approach from head to toe, head and neck, cardiorespiratory, gastrointestinal, musculoskeletal, also skin. Patient living with obesity might have various skin conditions, and this can cause repeated use of steroids. It can cause distress. It will disturb the sleep, and this is another important issues that increasingly we should pay attention to. And the presence of lymphedema, lipoedema, venous insufficiencies, ulcers, stasis, and thrombophlebitis also equally important because as we all know, this can become an infection, And patient again, when patient is having infection, this will make them unhealthy, and it will be difficult for them to manage their weight. So moving on for this patient, I had the opportunity to do a body impedance analyzer, and this is a standard reporting from a body impedance analyzer that give us the percentage of body fat and the skeletal muscle mass. This is important, especially for serial measurement. When the management of obesity started, we want to focus on reducing the body fat percentage. As you can see here, the percent of body fat for this patient is almost 56%, with the skeletal muscle mass of 31 kilogram. So we want to focus on reducing the body fat percentage while maintaining, if not improving, the muscle mass as well as the functioning of the patient. And this is another standard reporting for body impedance analyzer. It can also report a segmented analysis that we can use to support exercise prescription by identifying where is the low or asymmetric lean mass. For example, as we can see, this patient is the lean mass for the lower limb is lower compared to the upper limb. So this can give us some clue or idea to recommend more exercise for the lower limb for motivating targeted resistance training. However, we should look at exercise prescription should be still primarily based on the functional testing, the strength, the symptom, cardiometabolic risk, mobility, and patient goals, rather than using this segmental analysis alone. So what investigation you want to order for my patient? Can you share in our chat box? Okay, thank you for all the response. So these are what we do for her. We screen for depression, we screen for anxiety, and we ask for the stop bank, which come back as 4, means high risk for OSA. And she have some mild sleepiness throughout the day. We also do a fundoscopy. We shows moderate NPDR. We do A1C, of course, EGFR, urine ACR, LDL, TG. And I noticed from the chat box all mentioning the LFT. So I want just to highlight here that sometimes not all LFT panel have the AST. So you might want to be specific when you want to do a fit for score. You need to order for AST and to calculate the fit for score. Even though I believe most of the modern private labs, they will auto calculate, but still fit for score is still something that still very much neglected for muscle D and liver fibrosis screening. So there was a question whether there is any relevance to do a vitamin D, zinc level. Of course, a certain private lab do that. At the moment, there is no recommendation that we should do for all patients for this micronutrient of vitamins level. It should be very much started with the basic investigation and go by the symptoms before we order for a more thorough investigation. And there was also a question whether what kind of body impedance analyzer that should be used at the moment. As long as the body impedance analyzer are approved by the Medical Device Authority (MDA) in Malaysia, then we can use that for our setting. There is no specific recommendation on that. And the last question is, how do you approach disease staging for patients living with obesity? As mentioned before, obesity is very prevalent, but we want to prioritize our resource. We have a limited amount of time and tools. So how do we do disease staging for obesity? Can I have some response in the chat box? So yes, we use the Edmonton obesity staging system. So our patient is stage basically clinical obesity stage 3 with poorly controlled diabetes and end organ impairment, CKD, muscle D, intermediate fibrosis risk, dyslipidemia, and possible sleep apnea. So for this patient, our plan at that point of time is to do CGMS or more tighter SNBG to optimize the glycemic control, either using medications or lifestyle. And for the intermediate score of the FIT4, we at the moment the recommendation, at least for KKM, is to do GGT first. And if the GGT is high, to refer our hepatologist. And at the moment for OSA, it is more appropriate to refer either ENT or chest physician to do a proper sleep study. And for the moderate NPDR, refer to ophthalmologist. And we want to encourage multi-disciplinary management with the dietitian, physiotherapist, and occupational therapist. This means that we are not just referring them to the dietitian, but we want to manage the patient together. So if you have a dietitian that you know that you can refer, just give him or her a note that you want to have some feedback. How is the patient doing after the patient is referred to the dietitian, physiotherapist, or others? So that brings us to the end of this segment. I must thank all of you for your attention and engagement throughout this session. And I hope this framework and case discussion can give us some tools and tips to the management of obesity in our own setting. And I'm happy if there are any questions. Again, thank you for your kind attention.